Good afternoon and welcome to the Assembly of Osteopathic Graduate Medical Educators, AOGME webinar series. We're pleased to have you join us for this GME Development Series webinar on strategies to develop OBGYN residency programs in rural and underserved settings. My name is Austin Wetmore. I'm the Program Manager for GME Initiatives at ACOM, and I will help facilitate this webinar. Before we get started, I'd like to review a few housekeeping notes. This webinar is being recorded. The recording will be posted on the AOGME webpage within 7 calendar days. All webinar participants are in listen-only mode. If you experience technical issues during the webinar, please use the chat feature and we will assist you. If you have any questions for the presenters during the webinar, please feel free to submit them through the Q&A feature at any time. If time permits at the end of the webinar, they will respond to your questions. I will now briefly introduce our presenters. Dr. Ryan Spencer is the Gynecologic Oncology Fellowship Program Director and Director of the Rural Residency Track in OBGYN at the University of Wisconsin School of Medicine and Public Health. Dr. Spencer also serves as the Central Hub Leader for HRSA's Rural Residency Program Development, RRPD Technical Assistance Center. Ms. Lori Rodefeld is the Director of GME Development at the Wisconsin Collaborative for Rural GME, where she engages with stakeholders statewide and nationally to expand rural residency training. She also serves as the Director of GME Development for HRSA's RRPD and THC Planning and Development Technical Assistance Centers. Thank you again to Dr. Spencer and Lori for being with us today and for preparing this presentation. With that, I will turn it over to them.
Good afternoon, everybody. I'm here with Lori, who I will now count in my life, thankfully, as a dear friend, mentor, and someone who I love working with in the work that we do. I'm going to start sharing some slides. Lori will share some as well as we move along, and we hope to have time for some questions at the end. I'm really excited to talk about the things that we've learned and experienced and heard and observed in setting up OBGYN residency training in rural and underserved settings. Neither of us have any conflicts of interest related to financial relationships that we need to disclose. As part of our work for the RRPD TAC and the Teaching Health Center TAC through HRSA, we have numerous partners and key stakeholders. I hope that all of you know that if you have any questions that we can't answer on this webinar today, or that you aren't able to ask, that you can reach out to us, and we are happy to either answer those questions, and if we can't, we'll be very honest that we don't know the answer and can probably get you to someone based on all of these partners who will probably be able to answer those questions for you. Our disclosures related to our HRSA funding is that both Lori and I participate in the TACs. Both are funded through HRSA grants, which you can see here. And the content that we are sharing today is our content, is our opinions and ideas, is not endorsed in any way by HRSA, HHS, or the US government. Lori, I just want to make sure you're seeing my full screen of slides here, right? It's just set up oddly on my screen. Okay, thank you. I do have some non-financial disclosures related to the subject material, and it is that we are not going to make any political statements or endorsements, although a lot of policy related to rural healthcare does bring in some important political issues. And we will discuss that healthcare policy at state and federal levels at some points. We also want to acknowledge that pregnant and birthing people are the most inclusive and appropriate terms for the subject matter of OBGYN, obstetrics and gynecology. We will use the words woman, maternal, and maternity care regarding specific programs because these are the most well-recognized and most current vernacular phrases related to these issues at many levels. Our objectives are to identify the critical needs for specialized OBGYN care in rural and underserved areas and those implications for community health. We're going to evaluate different OBGYN training models, including rural tracks, teaching health centers, to help determine best fit for individual locations, programs, people. We will analyze common hurdles in establishing and expanding OBGYN residencies and examine essential tools and resources available for the development and sustainability of OBGYN residency programs. And with that, I'm going to start with a quick video for you all to really set the stage about why this is so critical.
One of my biggest fears and concerns going to Lubbock was, what if I deliver on the way there? We're in Terry County. We're about 30 to 45 minutes away from a big city called Lubbock, Texas. That's usually the city that most people in this part of West Texas, that's where we all go, because that's where, you know, like the bigger hospitals are. We were both a little nervous at first. It's like all of a sudden a response, like the responsibility just hits you, especially being first time parents. Um, it was like, oh my gosh, like I have another human being I have to take care of. From here to the Lubbock Hospital, we would have to drive from our house to the Lubbock Highway and all the way down and go through two other rural towns to get to Lubbock. And then the hospital is actually on the other side of Lubbock from where we're at. We have had quite a few people who are passing through here on their way to Lubbock, and they will deliver here because they just couldn't make it in time to Lubbock. Maternity care desert means that people can't get good care or any care in their area. So I'm from Lamesa, 30 minutes from here, and I chose family medicine because I wanted to go back to Lamesa. Lamesa no longer provides obstetric care. Living in rural areas, there's a lack of resources in general. There's a lot of poverty here. And there's actually even a lack of knowing where to go to get your resources. You have to be able to access websites, but what if you don't have internet? You need to go to an appointment, but you don't have a car. And if you live outside of the city limits, you know, you might not be able to find a ride. So what ends up happening is people just don't get care. They show up to the emergency department, and you have worse outcomes when you don't get any prenatal care.
I share that video with you to highlight the fact that all of us who are engaged in this work must put mission first. There's so many opportunities to be discouraged, to feel like we fall short, we don't get what we want and need, that we aren't serving the people we are meant to serve the best at all times through no fault of our own. But stories like this and others have to be what continues to drive us. We'll show a little bit more data to bring this point home. Maternal mortality in the United States has been on the rise for 15 years plus. The hard part is that it has been on the rise at a greater rate in rural areas compared to urban areas. This is a graphic from the March of Dimes. All the red dots are counties that are considered maternity care deserts, meaning they have zero obstetrician gynecologists or other obstetric care providers. What you'll see is these areas are concentrated outside of the coasts, and I've highlighted here areas where there is a high concentration of obstetric providers. These are places that are not in danger of having low numbers of obstetric providers, the coasts, and you'll see a lot of places in the Midwest, South, Southeast, Mountain West, Plains, affected by minimal access to obstetric care providers, with some others spotted in those other areas, even where there mostly are not. This is another graphic that shows in the darkest blue, counties that have no hospital and no birth center. So not only do they not have providers there, they have no means to provide obstetric deliveries in these areas throughout the United States, a striking amount of dark blue. We have a good understanding that, well, we often talk about this as a rural problem. There are urban underserved areas as well that qualify as maternity care deserts. More than 50% of rural counties have no hospital-based obstetric services, yet 1 in 3 women in metropolitan and urban areas live in OB deserts. And as we talk about 2 pathways here today, we'll talk about rural training programs. Lori's going to touch on teaching health center training programs as well. That's a potential opportunity to help improve those patients who live in these more urban maternity care deserts. Unfortunately, what we know is the most affected by the lack of OB care are those who can least afford to lose it, and they're losing it at a much greater rate. If we look all the way to the right-hand column here, rural counties with less than 10,000 residents, of which there are a significant number in the United States, you see there are nearly 1,400 counties with that demographic. 58% of them have never had OB services, ever. 10%, 11% of them have lost all of their OB services, and only 30% of them have continual OB services in the most rural counties. As you can see there at the bottom, 139 OB unit closures taken into account from the mid-2000s through the mid to late 2010s. Bringing it home to me, Lori and I both work and serve in Wisconsin. There's a reason we got into this business is because of graphs like this. On the left, you'll see highlighted in dark purple are maternity care deserts in Wisconsin, counties with no obstetric providers of any kind. On the other side, on the right, you'll see the additional counties in Wisconsin. This isn't an overlayment. These are additional counties that are considered low access to maternity care by the March of Dimes. And here's how we get those definitions. Maternity care deserts are 0 hospitals or birth center offering OB care with no OB providers. Those with low access have less than 2 hospitals or birth centers offering OB care and less than 60 OB providers per 10,000 births in those areas. For context, in the United States, in 2020, deaths related to childbirth had increased by 14% from just 1 year earlier. Deaths related to childbirth increased by 30% from 2 years earlier. So not only are we on an increase, but a stark one. While maternal mortality has decreased in many other countries, not in this one. We know that 50,000 childbirths are complicated by severe maternal morbidity mortality every year. And the CDC data clearly tells us that maternal mortality is associated with the county that you live in, just by living in a certain place. And I think the data we've seen in these last few slides can tell us why that might be. We don't have the skilled clinicians in acute situations that are needed. If we talk specifically about the rise of maternity care deserts, even recently, in 2022, the March of Dimes reported that 36% of all US counties are maternity care deserts. And in fact, between those 2 years of these reports, an additional 2.8 million women of reproductive age and 160,000 additional births were affected by the decreased maternity care access. Shifts in the number and location of obstetric providers is the primary reason for these declines that are seen. And here's a graph that's very interesting. It's not as though there are no places getting some increased obstetric care. There are some. However, the balance is towards loss. And what you'll see on this graph, the dark purple going upwards are the number of counties that had increased level of obstetric care. The lighter blue going towards the bottom, those that decrease, and you'll see there are more decreased. The second part of information that this graph provides is the reason that they've gained or lost. And what you see in the loss category is 58% of loss of obstetric care services between these years was because of the loss of obstetric providers. I'm not meaning to say that this is a simplistic issue that we're dealing with. I'm not suggesting that. It is multifactorial and it is complex. However, we're talking about the one piece that is the greatest part of that pie, and that is loss of OB providers. We know that. The Institute for Healthcare Improvement a few years ago put out a report to discuss the disappearance of OB care in the United States. And what they found are things that are not surprising: lack of access to services, limited clinical expertise in obstetrics in general, loss of supplies and equipment of hospital units, a rural physician shortage, rural healthcare providers shortage who are non-physicians, and increased complication in care transitions were all issues they noted. They also provided an opportunity at that time to talk about different reasons how we might improve those issues that we're seeing. And I've highlighted here in yellow ones that were specifically interesting for me in the work that we do. And in the primary drivers, you'll see to build a pipeline of maternity care professionals. And over in the secondary drivers, things like establish rural residency programs, encourage family medicine rotations and residency programs focusing on obstetrics in rural areas. And then not only trying to get new people to go into obstetrics in rural areas, but what are the things we can do to help people feel valued, but also more comfortable in providing obstetric services in rural areas where they are now? And things like providing subsidies for CME, increased training, increasing simulation events and activities, incentives to practice in rural areas. As you look down at the bottom there, how do we reduce the financial burden on health systems of providing maternity care? Because this is a complex issue. How do we, from a policy level, work with our elected officials and our government agencies to examine how we cover the benefits, the reimbursement, payment, and managed care that often limit access to the best quality maternity care we could provide in every place that people are living, not just in a percentage of them. So we come to this part where, what are the ways we can get people into those locations? Can we do it? Is there data? What's best practice? There's a couple of papers I'm going to go over in the next couple of slides that provide us a pathway to understanding how we can do this. Here's an analysis of the distribution of practice location of family medicine residency graduates who were in residency from 2008 to 2012. And we're looking at them now 6 to 10 years on outside of residency. And what we have in our table here on the left-hand column is the percent of time that those physicians spent training in rural locations during residency. And going across, we see what percentage of them are now practicing in urban settings or in rural settings, based on the amount of time they spent training in rural or urban areas. And we see a really interesting divide. At 50% or greater, the number of people choosing to practice in a rural setting after residency jumps multiple fold, from anywhere from 13 to 20% going into rural training or rural practice after a small percentage of time spent in rural training, to over 50% in some cases if they practice, if they train a majority of the time in rural locations. And what we see in that analysis is in family medicine, if you provided the opportunity to train during residency in rural areas greater than 50% of the time, the odds that you would end up in a practice in a rural area is 5 to 6 times as great. It's a stark number, and truly shocking how great that difference is, that just by offering these experiences, that residents choose ultimately to practice in rural areas. This is another paper, once again, analyzing family medicine residency training programs. I realize there's a lot of numbers here and we can all get p-value fatigue. That's why I highlighted the yellow ones that are most important. What was done here in a really nuanced analysis is at the top, you'll see they looked at people in family medicine residency training. How often are people from a rural background or an urban background choosing to practice in rural settings? So what it shows here, if you're from a rural background, almost 40% of residents chose to practice in a rural setting, just by having a rural background. So if we talk about pathway programs, there's step one. How do we get into communities as medical educators? How do we offer experiences in healthcare that help get people who grow up in rural areas interested in medicine as a career is the first step. However, a couple blocks down there, you'll see residency program location highlighted. People who did residency in an urban location predominantly, only 18% of them ended up in rural practice. However, greater than 50% ended up in a rural practice just by having residency. We just saw that in the last slide. That's essentially almost the same exact number that we saw before in the last slide in a totally different paper, totally different analysis, totally different set of data. The last box is the most critical. This interaction between rural background and rural residency program location. If you look at the last line, if you took someone from a rural background and gave them an opportunity to be in a rural residency program, over 80% of those residents practiced in a rural location. In fact, what you'll see in the 2 lines above that is the most important factor was actually training in a rural residency program, not if they were from a rural area. Even people from an urban background who were in a rural residency program went into rural practice 42% of the time, above only 39% from a rural background in. So what we see is training matters more, and the interaction between training and background matters by far the most. So enough on background. I want to go through some key definitions that we might touch on throughout the rest of our slides and in our conversation that we hope to have. There's different kinds of rural training. There's programs that are located in a rural area, and they train the residents entirely or near entirely in those areas, except for some particular rotations that they might need to have at larger hospitals because they're required. A rural track program has a specific definition from the ACGME, in which all or some residents or fellows have both urban and rural experience. In order to be classified as an RTP by the ACGME, you must train those residents for more than 50% of the time in a non-metropolitan or quote unquote rural area based on the core base statistical area they're located in. A rural track is a dedicated track within a residency program that offers less than 50% of time in training, otherwise it would be an RTP. And it offers 50% or less than 50% of time training in rural locations to specific residents within a program. And then there's some areas that have rural rotations that are specific clinical experience or rotation that can either be put in place for all residents to rotate through at one point, or be an elective rotation available for a resident to participate in a rural location. We're predominantly going to discuss RTPs for this talk, but we'll certainly happy to talk about these other opportunities too, and we'll probably mention them along the way. So I want to highlight, and we got some questions before this talk, and so we wanted to make sure we spent some time here. We are, if nothing else, very open and honest about what we experience and the pearls and wisdom we might have about things people have encountered, both positively and in challenging ways. So what I put down here, the top things that I have heard and observed and seen and listened to from the program perspective and from a clinical partner perspective. The program perspective meaning like an urban site in an RTP, and a clinical partner perspective like a rural site in these rural experiences. And some of these things overlap, like interested clinicians, really important for both. Recruitment and retention of faculty, really important for both. There's some things that are unique to each of these parts of the relationship. And not that all aren't intermingled, but I think understanding the perspectives of each organization involved in creating an experience is really critical to the success. So we want to go over a few of these and highlight them and what they are. There's going to be some QR codes coming up. So if you're a QR code person, go ahead and get your phone and just know there's going to be a few coming at you that are critically important. If you're considering an RTP in any specialty, you must know this PowerPoint presentation by Lainey McDougall, one of the greatest humans I personally know. Lori would agree, I'm sure, who is the director of the MUAP program at the ACGME. This is a PowerPoint presentation. There are documents that go along with it. It will guide you through every step of an RTP. An RTP can be done through a complement increase to an existing program or a whole new program application in which you plan on having the new program be an RTP. So scan this code. It's a really critical thing to have. I want to touch a little bit from the program perspective on something in OBGYN that is critical when you're thinking about rural experiences, especially if you're thinking about an RTP. And that is the procedural volume and clinical material that you need to have at a rural clinical partner site in order to even consider being successful for these things. And when I talk to people around the country about this, this is one of two things that is brought up every single time, from rural partners that I talk to, from urban residency programs, from the times I've spent with the ACGME, interviews and opportunities I've had to present to the RC at the ACGME about this. This comes up almost uniquely as the first thing. And what I wanted to do, once I get into their QR code here so you can keep this slide, procedural focused training programs have some unique concerns when thinking about establishing rural programs. And this is one of the big reasons. You have to accomplish these minimums and at program application, be able to prove that you're going to be able to offer these minimums to the residents in those areas before you're even going to sniff accreditation. And you have to consider, most of all, that a place must have advanced GYN surgeons available. Because the most of the GYN volume residents are going to be in those latter years of residency. If you're thinking about setting up an RTP, you've got to think about an OBGYN, essentially 2 years in an urban site, 2 years in a rural site. Most places are going to think about doing the first 2 years, when I've spoken to them, in their urban site, getting them the foundation, busy obstetric volume, basic delivery skills, basic cesarean skills, basic gynecology skills, and most all residency programs in OBGYN are then saving a lot of that advanced GYN volume and advanced surgical obstetrics volumes for years 3 and 4. You have to know that that urban site, or sorry, that rural site not only has these advanced surgeons available, but in the volume that you need. Generally, PGY3 and PGY4 are the highest volume years for these. So these are the procedures that I tend to look at when talking to places and letting them know you've got to make sure you're going to be able to offer this volume. The majority of abdominal hysterectomies are going to occur, vaginal hysterectomies, laparoscopic, all these are going to occur in years 3 and 4. What I've done here is I've anonymized this and called it urban program and rural hospital, but this is an actual analysis that I performed on a proposed RTP for OBGYN. And so what you'll see is in red, the minimum volumes. What you'll see in that next is what is the average number that a PGY2 is leaving the urban program with for these major procedure volumes. And what you'll see here, good chunk of deliveries, good chunk of C-sections. I will tell you this particular program ends up at about the 60th percentile in the country for vaginal deliveries. So that's a pretty good representation. And ultimately ends up at about the 70th to 80th percentile of C-sections. So this program generally graduates residents with about 260 vaginal deliveries, about 280 cesarean deliveries, about 45 operative vaginal deliveries, about 18 to 20 abhysts, 15 to 20 vag hysts, and about 80 to 100 laparoscopic hysts. That's what this urban program offers. So when you see that here. And then you have to take the projected number available at the rural hospital. You have to think about how many residents you're going to send to that rural hospital in the RTP. Are you going to send only one? I think that would be a really hard sell for the program, for the residents going there. Not that you can't do it. I think it would be challenging. Are you going to send 2 per year to that RTP? If you start doing that, you have to start thinking about how are you going to divide those numbers so they all get them. And so this is the analysis that we ultimately did to help them to see what are the projected totals available by the completion of the RTP. Now, of course, you don't need 400 vaginal deliveries, nor do you want them. You don't need or want 400 cesarean sections. You're going to concentrate their experiences in that gynecology volume area. Make sure they get to every vag hyst, make sure they get to every ab hyst, make sure they get to as many laparoscopic hysts as they can, and make sure they get all those operative deliveries. So not that they're going to get all of these, this is an overwhelming number in some cases, but it's just an analysis of what that hospital offers based on the number of residents this particular partnership was proposing for an RTP. And you must do this for yourself to know if it's feasible. You must do this for the ACGME. Interested clinicians seems like a no-brainer. I have consulted with a location that was wanting to set up an RTP. And at our first meeting, they told us the administration was on board. They had no idea if the doctors there were going to be interested and want to help. Now, what I told them is that's a good place to start then. I mean, I'm not giving you that story as a pejorative. I'm just letting you know, you must at some point figure out if the clinicians are going to be on board or the pathway to help get them on board. Or if 1 or 2 are on board, who are the champions? What sway do they have with their partners? How do they get them interested? Because that's how you get a positive teaching environment and culture. And that's really critical. I will tell you how we've gone about that in our rural track. I put over here on the side, it's networking, it's going to meetings, it's meeting people like Lori. Lori is the one who got us into SSM Health Monroe. What you'll see here is our urban site is in the black star in the South Central state. The little blue stars are our current rural track partners in Wisconsin. We've all met them through different pathways and through different networks. Some of them I stumbled on cold calling or cold emailing after I literally took the Wikipedia page and said, who are all the people that have OB doctors in Wisconsin and hospitals that deliver babies? And I'm going to send an email to all of them. After a while, if you have a good media relations department, you get some advertisement, they start calling you a little bit and they start to get interested. Word of mouth. And the most important thing I can tell people to do is actual FaceTime. I have been to all of these places. In fact, in some cases, I've insisted on going to all of these places for recruitment of their faculty, for recruitment of their administrative leadership, to put in FaceTime and show them there's an actual person here who they can call and who they can rely on, and to show them we are serious. I'm spending 3 hours traveling to Baldwin, to your 12-bed community critical access hospital that has 2 labor, delivery, recovery, postpartum beds for a reason. It's because we want to be here. And I will tell you, Baldwin since then has now joined and now takes general surgery residents from our rural track. And I know that they are interested in growing their GME footprint. Meetings, you're going to have to spend the time. You're going to have to put in the FaceTime and get to know them. It's so critical. As I mentioned, motivated administration is the other piece, and that ties in a little bit with funding. Administrators want to know how this works. Where does the money come from? Does it provide value to their organization? What value does it provide to their organization? They want to know these types of questions. So you do have to have some working knowledge. You don't have to be an expert, but you do have to have working knowledge so that at those initial meetings, they are still interested at the end of it and not turned off. I'm going to touch a little bit here on two really important documents. The QR codes are there. As far as funding, and something really critical, is in specific situations now, thanks to, there's specific situations that urban and rural partners in RTPs can receive a resident cap adjustment upwards, thanks to the Consolidated Appropriations Act of 2021, Section 127. And while everything that comes out from the federal government is lengthy and is very complicated, I hope these 2 documents can give you some guidance. The Section 127 QR code goes to sort of like a summarized idea of what this means for RTPs. And the AAMC Rural GME update is a free document you can get to just by signing up for it and has a lot of good explanations. I've taken this one table from them because what I want to highlight here related to funding is this opportunity to get a cap increase with an urban plus rural partner RTP. And what you'll see here is how can you get funding? If the urban hospital establishes a rural track, the rural partner and rural hospital site participate with the urban hospital for an RTP. If you just scroll down here, cap adjustment to the urban hospital participating in an RTP, check. Opportunity for cap adjustment to the rural hospital participating in an RTP, check. There are lots of subtleties and nuances to this, but it has opened up a whole new world outside of family medicine for other specialties, including OBGYN, to have an opportunity to get funding to start RTPs, be something that administrators at your urban hospital that is probably capped can be interested in doing, because you can get additional dollars by revising your cap adjustment up in an RTP for your urban home hospital. And also the same can happen for your rural partner site. So real game changer here that we hope people can start taking advantage of in the world of OBGYN. And again, those QR codes will take you to those documents that have a lot more information. This slide could probably be its own hour talk, to be honest. So I don't mean to gloss over it quickly. It's just impossible to spend enough time to get through all the nuance. Just know this is a really important new opportunity for all specialties. I want to touch on scheduling a bit, because if you have, as I mentioned, an RTP can be done through an existing program, complement increase, or a brand new program. And if you're going to bill an RTP out of an existing program, that means a lot of schedule changes. You'll have additional residents in PGYs 1 and 2 that you won't have then in PGYs 3 and 4. And you've got to figure out how to deploy those so it doesn't upset the balance of teams, that it doesn't upset the clinical care you provide. So I just provided this an opportunity of a recent RTP that I worked on to help get a schedule in place, so they had at least a framework or a shell of what they would do with additional residents in PGYs 1 and 2 that they would not have in PGYs 3 or 4. Also, I put on the side here, understanding an OBGYN, we have that requirement for 120 half-day continuity clinic sessions that must be completed by graduation. In our rural track in Wisconsin, which trains residents for 6 months, that is not an RTP, it's a rural track. This is what our schedule looks like. We take our rural track residents out of ambulatory-based rotation, so they aren't missing procedures. And we have them go into the rural locations, which I will tell you is predominantly allowing them to get ambulatory experience in rural areas rather than the urban site. And additionally gives them some procedure experience in those rural areas. So we really think it's the best of both worlds. They don't lose out on ambulatory care by going to the rural sites. They actually just get rural ambulatory care experiences and also the opportunity to have some procedures in those rural areas. So that's how we've scheduled it here to be able to accommodate that for our rural track in Wisconsin. Lori?
Great, thank you, Ryan. Want to talk a little bit, beyond rural programs, also talking about opportunities that exist with teaching health centers. We are, seeing growing interest in, beyond rural, creating teaching health center GME programs that will meet the needs of our underserved urban communities, which Ryan alluded to in the maternity care deserts. It isn't just rural communities that are impacted. Even in Wisconsin, we've had urban hospitals close their OB units, and typically those are safety net hospitals that are serving those patients. And the reality is we have urban underserved patients that need care, and teaching health center GME is an option and an opportunity to create an additional type of program. And, some of the barriers Ryan was talking about with regard to, can you get the hospital experience? If you're able to find a partner within your urban setting that can be a THC GME program, it can be a really viable path forward with THC GME funding, which we will talk about in a little bit. It is important to note, that you need to be an eligible entity, which HRSA defines as a federally qualified health center, a community mental health clinic, a rural health clinic, or a consortium, or an IHS clinic. The consortia, they would need to have a partner entity, which would be a health center. But, I know many of our osteopathic, colleagues on the call today are part of consortia. So this could be an opportunity to look at a different model. If you do have a health center that is interested in OB and has again, an engaged clinician, as Ryan said, who's interested and could provide support for that type of training. So next slide, Ryan. And you'll see on here, there are many eligible specialties that HRSA does support with THC GME. And one of those is OB-GYN. I want to also give the disclaimer that there is not currently a notice of funding out with HRSA right now. We are hopeful that there will be a notice of funding later this year. But right now, currently, HRSA is funding and awarding the current resident PRA is $160,000. And I would encourage you to review the notice of funding and see if you have eligibility to create a THC GME program. But again, funding is a key barrier if you're looking to develop a residency program in a rural or underserved area. So kind of identifying what path forward you're going to pursue is very, very important. And on the next slide, we'll talk a little bit more about that. You'll see in red, it's competitive and limited funding. But again, the program perspective and the clinical partner perspective are almost the same as what we described with regard to rural. Again, the two biggest barriers that we see in developing new THC GME programs are funding, faculty recruitment, program director recruitment, and then also hospital partnerships. So if you can, leverage some existing hospital partnerships in an urban area through a consortium or through a health center, this can be a really great path forward to look at OB-GYN programs in teaching health centers. And on the next slide, we've got a map, and we only have 3 existing teaching health centers that are OB-GYN, even though this is an eligible specialty. So I think that, this would be great to see this map light up with even more teaching health centers that are OB-GYN programs, but you'll see, there's one in California, one in Oklahoma, and then one in North Carolina. And I would encourage you, if you are near one of those programs, to connect with them to find out, what their curriculum looks like, how do they structure some of these experiences, and I would even encourage you on the rural side to do the same. Talking with folks like Ryan, it's invaluable to connect with someone else who's already done the legwork, who's already set up the program, who knows the barriers, who knows some of the common challenges, but then also to hear their success stories. I think that that's really important as well. And I hope Ryan will share a little bit more about, his great program and the successes that they've seen here in Wisconsin. So next slide, Ryan. We do want to connect you with our resources through the Technical Assistance Center. We have 2 websites. We have Rural GME, which was just recently updated and refreshed. So if you've not visited Rural GME recently, take a look at our new website. You can create an account just clicking on I want to get started. And all you need to enter is your email address, you set a password, and then you'll have full access to our resources and our tools. HRSA has graciously allowed us to share these with the broader GME community. And then our Teaching Health Center site is in the process of getting updated. So hopefully within the next 6 months, it'll have a similar look and feel, but you can do the same. You can register, get access to our tools and resources. You also do get invited to our webinars. We have some amazing webinars. We were talking about Section 127 earlier. We actually just last week did a webinar on Section 127 and expanding programs via complement increases. So I would encourage you to watch that webinar if you've not seen that already. And we actually highlighted a couple of psychiatry programs that expanded via complement increase. And I'm really excited about Section 127 and its applicability for OB-GYN programs, because it's a fundable path forward to support this. And if the volumes may not line up for, say a 51% rural program, it's easier to do that complement increase because you can still get volumes, but you just won't need volumes for as high of a number of residents in a complement. So Ryan, next slide, please. So we have many resources and tools available on both Rural GME and THC GME. This is my view, so I have access to our program information and our reports, but you'll see those top 2 resources. We have the Getting Started link, which has our roadmap for GME development. I'll talk about that in just a little bit. What is also really great is we actually have timelines, and we have timelines for all specialties that are supported by HRSA. So we do have an OB-GYN timeline of how you could get a program launched within 2 to 3 years to kind of see what are the key steps, the key milestones that you would need to take in order to achieve accreditation. And then in our toolbox, we have our webinars archived. We have resources, including accreditation documents. We have best practice tools, resident manuals, sample agreements, block diagrams. We have a block diagram for OB-GYN. So we're really working to build those OB-GYN resources as well. So please take a look at our toolbox. I will highlight those in an upcoming slide as well. So Ryan, next slide. Yeah. So when you register for your free account, these are just a few examples that we have that really relate to OB-GYN. And like I said, we do have resources that are specific for that, like the block diagram, mission and money, learning about rural financing in general is really important as you're considering an OB-GYN residency. And then also, Ryan and Ann O'Rourke did a presentation on creating and sustaining rural residency tracks in surgery and OB-GYN. So if you've not taken a look at that webinar, definitely take a look at what they put together. They're both leaders in this space. Next slide, Ryan. So this is our roadmap for GME development. So if you've not seen this already, definitely log into our portal. You can download this roadmap for program development, really see what our tools and resources are. There's 5 different stages that have been developed. This was developed by some key experts in the GME world, kind of focusing on what are those milestones that programs need to achieve as they're developing. Stage 1 exploration is going to be, those initial outreach activities like Ryan was talking about, like talking with interested faculty or interested administration who have a vested interest in this work, identifying who are the key stakeholders who are going to be involved in this program, who's going to sponsor the program. Sometimes you may be working with a rural hospital that's a unicorn and they can create their own program. They can sponsor their own program. So that's going to look really different than if you have a great partner like Ryan at the University of Wisconsin, where they already have a sponsoring institution set up. And then from there, you'll move through design, development, startup, and maintenance. And what's really great about this roadmap is that it's not a linear process. You may identify a program director right away in stage 3, and then that can help move the whole process along, hopefully more quickly, because you have that key champion at the rural site or within the program. So again, take a look at this roadmap. It's a really great tool as you're trying to sit down and quantify, how do I get started with this new program? Next slide, Ryan. And really excited to share this addition on our new website. We actually have all of the rural programs that are supported again by HRSA, the specialty supported by HRSA. You can look and see which programs are offering rural training, but then also which programs are offering more than 50% rural training, and you can sort by specialty. So if you do want to see, what OB-GYN programs are out there offering some kind of rural training, that's where you're going to find great tracks like Ryan's program. But if you want to see what are the actual, RTPs or, rurally located programs that have over 50% of their training occurring in rural areas, you'll also be able to identify that on our map. So it's a really great tool just to kind of see, who's in your neck of the woods, who's doing rural training, and what are they doing. And again, I love reaching out to programs, hearing their stories, finding out what they've done, how they've done it, because we can learn a lot from each other. So next slide, Ryan. So we are happy to help you. Ryan has a QR code for his email. Mine isn't there, but you can email me or email info@ruralgme. And we'd be happy to address some questions. I see we had one that came through already, Ryan. And that is, if a resident takes vacation during a rural month, will that affect the 50% CMS rural requirement?
Yeah, that's a great question. So it has to be 50% of their planned time in the program in a rural area. So that does not count things like vacation. Vacation is part of their planned time in the program. They have to be offered vacation. So it does not get as granular as they took 3 weeks of vacation in PGY3. They were supposed to be in the rural area, so they have to make up 3 weeks somewhere else. It is greater than 50% of the planned curriculum and then time spent in the program in that location. So it does not count time away like sick time or vacation. Good question.
Question. Brian, I'm wondering, you didn't share a lot about your program, but the rural track that you've created in Wisconsin, do you want to talk a little bit about the funding for that program and how that's supported?
Sure. Yeah, absolutely. Why didn't I'm going to touch on one of the questions we got beforehand first, and then
Great.
segment that, if that's okay. Someone asked how many rural OB programs are there right now? And we didn't touch on this a lot. There are a couple of different, there's probably a lot of different ways to define what rural is. However, if we're going by the definition of who's eligible for Medicare GME funding, we're going to talk about, once again, those places, those programs that are in non-metropolitan core-based statistical areas by the U.S. Census. There are two programs, or is one program in a non-metropolitan CBSA. It is Dartmouth. Dartmouth is a great institution, but I don't know, until I started doing this work, I thought about an Ivy League academic center as a rural institution, but it technically is. There's one other OB/GYN residency program that is primarily located in a Federal Office of Rural Health Policy designated rural area that is in Galveston, Texas. Once again, that's a city of greater than 50,000 who, in a lot of other ways, when you're there, might not seem rural, but it is in that area and defined as such. Other than that, there are no currently approved OB/GYN RTPs that exist. There's some in development, but that's all we have right now. Other than that, there are 2 programs that have dedicated rural tracks, so less than 50% of time dedicated to rural training in OB/GYN. We at the University of Wisconsin have one, University of Iowa has another, and there are a handful of places that have either rotations or elective opportunities. In our program, we have a separate match code. We have 7 residents total per year. One of them is matched into the rural track match code. So they know that they're going to be spending a total of 6 months in rural areas throughout their 48-month training period. I showed you the map of our partners. We have our residents rotate through various of those partner sites so they can get a variability of rural practice. I think any of us who do this work realize not all rural is created equal. As I said, we have a 12-bed critical access hospital as one of our partners. And we have another partner who has 800 deliveries a year and 200 laparoscopic hysterectomies and its own GME programs that happens to be in a rural area. And so rural can look very different. And so that's why we want them to get that experience. As far as our funding, because we're less than 50%, we do not get additional Medicare GME dollars for those residents. However, we have been lucky that our state has a funding program for rural training that allows us to get money for the salary and fringe of our residents for the time that they spend in those rural areas. So through that and some other grants through the University of Wisconsin, we've been able to support our program for those residents spending that time in rural areas. We have to account for their salary and fringe in those locations, as well as most of them require a hotel stay, an extended stay hotel for that time, which is money. There are some now opportunities for critical access hospitals to be able to get additional Medicare GME dollars. Once again, that's one of those nuances, not fit necessarily for the conversation today at length, unless someone has a specific question. But once you are getting to the idea of really wanting to develop a program, no matter what type it is, but certainly an RTP, you want to make sure that you have a GME finance expert on your consultant team, because they're going to be able to help you with those nuances of it being a critical access hospital. What are the GME dollars you could expect to get on a cap increase from both the direct GME dollars and indirect for both your urban site and your rural site? Are you in a Lugar County? We won't get Lori started on that. She's too much of an expert. But there are nuances, and it is confusing and it is complicated, but there are much more pathways now to financial sustainability for RTPs and OBGYN than there have ever been before, thanks to the 2021 Consolidated Appropriations Act.
And I just want to really amplify what Ryan, mentioned with Section 127. I know I've had conversations with, academic medical centers that are looking at, we have an OB-GYN program, we would like to set up an RTP, but again, concerned about volumes. And, there is a path forward with Section 127 to do a complement increase, because then you can still utilize the volume that you have at the rural hospital, but it's just an additional one resident per year versus, having to have the minimum complement. What is the minimum complement required for OB-GYN, Ryan?
It is 3 per year. So
Yeah.
you have to accommodate 12 total residents. And most programs out there are well above that. There's not a lot of 3 resident only programs. There's some, but that's a significant number.
Yeah, so I think, keep that in mind. And then Ryan brought up state funding. So I would definitely look at like what's available within your state. It's interesting. A lot of states do, provide Medicaid, GME, or expansion grant funding, which can help support the salary and benefits. If you can't get to the CMS funding level, or if you're not, looking at a Section 127 complement increase. One of the questions we got that I want to make sure we address is there was a question regarding OB fellowships. And, again, that's for family medicine. And, we're seeing, I think, an increase in uptick, at least in Wisconsin, with OB fellowships. Up until last year, we only had one, and it was limited to grads of one particular family medicine residency program. And it didn't necessarily have a rural emphasis, but how they structured that program was that residents who wanted to stay on for a 4th year were able to do so, and it would be like their OB fellowship. The nice thing about that is they actually got, partial Medicare funding for that. They get half their DGME plus full IME for the time that the fellow's with them. The downside of that model is that then they only can recruit their own residents into the program who then stay for that 4th year. It's a path forward. Is it the right path? It depends on, the program and, what the mission is, and if that seems to be a fit. The other 2 new fellowships that we've created in Wisconsin, we have GME planning and development grants, and both fellowships receive planning and development grants to launch their programs. One is in the western part of the state in La Crosse. They created their fellowship. Their first fellow will be starting this summer. And it's a partnership of both Gunderson, because with OB fellowships, even if there's a rural emphasis, the reality is they need substantial OB training to be able to do operative obstetrics. So the bulk of their training still will be in the urban site, but that site is looking at, I believe, 2 months of rural rotations. But again, they're funded by They're funded by the Planning and Development Grant, and then the actual fellow salaries will be self-funded by the health system that's supporting that program. The other program is actually partnering with Ryan's program at UW to provide a lot of like those higher volume OB experiences in Madison, and then they have several rural partner sites providing mentorship and kind of real world rural experiences. And I believe that they are looking to apply for a state grant to hopefully receive sustainable long-term funding for the actual fellow salary and benefits. So those are two models. And Ryan, I don't know if you want to add anything to the OB fellowship that you're partnering with.
I think that when we talk about how, as I tried throughout the early part of the presentation to not say obstetrician gynecologist, I stumbled a couple times. Although I do think it's important to have obstetrician gynecologists in communities, we're really talking about skilled obstetric providers in a lot of these cases. And one of those pathways, I believe strongly, should be RTPs for OBGYN residency, but also helping as an urban center with a lot of volume. How do we also promote training skilled obstetricians who come there from family medicine? And how do we partner to make sure that we know, one, that we're doing that for the benefit of our communities, but also being considered good citizens and sharing that clinical material with an additional number of people who want to practice obstetrics. And I think for us, that's an exciting proposition to promote additional OB fellowship pathways from family medicine because of that.
No, thank you, Ryan. Another question that we got that I'd be interested in your perspective on, Ryan, is how can administrators, legal and finance be helpful to program leadership in developing programs?
Yeah, once again, this subject matter is so rich and we could do so much about it. We didn't talk a lot about, a little bit, we didn't talk a ton about who has to be on that team as you're looking to develop one of these things, right? And essentially the person has answered the best part of this question with the question itself. If you're looking to have and start a rural track like ours that is not yet 50% of the time in rural training, or an RTP, it requires making sure that you have administrators on that team, you have someone in legal on the team, and have someone who knows about GME finance on your team. And I would say it's about maybe more than having them help you, it's about managing up. I bet you're going to come into a relationship with any of those groups of people with more knowledge about the need in rural areas, with more knowledge about rural programming than they might. And helping manage up and getting them up to speed on what they can do to help you from the outset. Inform them about the different funding pathways that you think may be viable. Ask them to help look into some very specific things to you. Be specific in what you want and need from them. Don't be general about your questions. Learn enough to be very specific. It is my recommendation. You're probably going to be the person that needs to drive that mission at each step. And I think clarity is the most important thing you can do. And I would say to get knowledge you don't feel you have or feel uncomfortable with, please do not go at that alone. There are plenty of us out there who have made all these mistakes, who have wasted 6 months of their time trying to figure something out. You don't have to do that. You'll have your own roadblocks, you'll have your own challenges, but I would say, please don't go at this alone. There's a lot of free resources. I talk to so many places, and for no other reason than I want to. There's no money that I charge. I don't consult and ask for money from them. I literally spend hours of my time just giving people materials and talking to them. There are many other people who are willing to do that. And there are some times when you do have to consider a paid consultant for things like finance and other things. And I would just say, be prepared to know that when you step into the room with those groups of people, you are probably going to be the content expert about rural training and need to ask them very specific questions about what you need from them about how the financing might work in this specific situation. I think that's the best thing. Just know that.
Perfect. Thank you, Ryan. And
Yeah, of
I just
course.
want to reiterate that, this is, a community, our, rural GME team, THC GME team, we are here to help. So you can email our inbox, info@rural GME, info@THC GME, or you can reach out to Ryan directly. I know he's a really great advocate for this work, and he's the champion, kind of leading the way to help us overcome some of these obstacles we started out discussing at the beginning of the webinar. I also want to just make a quick plug. Juana had asked in the message to us as panelists that we do remind you that we have AOGME, which is another community where you can join the monthly meetings. You can bring up your questions, your concerns. That's a perfect forum to really continue to connect with the greater osteopathic community growing GME. So I think we'll hand it over to Austin. Thank you so much for hanging in there with us late in the day today. It's been a lot of fun sharing and answering the questions.
And thank you, Lori, for all you do. You do a ton, and I learned so much from you, and it's always fun to present with you.
Yeah, thank you so much, Dr. Spencer and Lori, for this great presentation, and to all who joined us. If you have any questions, please contact us directly at aogme@acom.org. This concludes our webinar. Thanks again to everyone who joined us, and have a great evening.
Bye, everyone. Thank you. Thanks, Austin.
Thanks.